Hello and welcome to BAUS e-poster session 4 on renal cancer, testis cancer and sarcoma. I'm Jim Armitage, consultant urologist at Addenbrooke's Hospital in Cambridge. I'll be co-chairing this session with David Thomas. The first 7 posters in this session have a similar theme and relate to the management of small renal masses. I'm going to summarise these and offer some comments before handing over to David for the remainder of the session. The first poster comes from the Royal Free and UCLH. They present a large cohort of patients with small renal masses undergoing biopsy in accordance with their standard care pathway, where all patients are offered biopsy. So 645 patients were offered biopsy in a 5-year period, 87% by ultrasound guidance and 13% by CT guidance. Tumour size was the strongest predictor of a non-diagnostic biopsy. So for tumours smaller than 2 centimetres, there was a 42% non-diagnostic rate. For tumours more than 2 centimetres, the non-diagnostic rate was only 14%. CT-guided biopsy was less likely to be diagnostic, reflecting selection bias, and cystic lesions tended to were less likely to yield a diagnostic biopsy as expected. So these results were somewhat intuitive. Their take-home message is that the larger the lesion, the more likely you are to obtain a diagnostic biopsy. These figures are important when counselling patients about the pros and cons of small renal mass biopsy. And I wonder whether their findings would influence their use of biopsy in all patients. For example, a 2 centimetre, difficult to access partially cystic mass in a young fit patient, would they consider undertaking robot-assisted partial nephrectomy without biopsy? Or for an older patient with comorbidity, where active surveillance is likely to be favoured, could biopsy be avoided? I think these are considerations that reflect practice in many centres in the UK. The next study comes from the University of Dundee, and this study acknowledges the difficulty of differentiating between renal oncocytoma and chromophobe renal cell carcinoma on renal mass biopsy. They investigate the possibility of using copy number variation, chromosomal characteristics to differentiate renal oncocytomas and chromophobe renal cell carcinomas on the basis of renal mass biopsy. They used a technique known as molecular inversion technology and analysed the entire genome of these patients. They looked at 15 cases of either renal oncocytoma or chromophobe renal cell carcinoma identified on small renal mass biopsy using histological analysis. So they found loss of chromosomes 1 and 14 in renal oncocytomas as expected, and loss of chromosomes 1, 2, 6, 10, 13 and 17 in chromophobe renal cell carcinomas. There is a suggestion that these findings were not consistent for all patients on the basis of their visible data, and I wonder whether their visible data would have been strengthened by some statistical analysis to support their assertions. Nonetheless, this is an interesting study that has promise in improving the differentiation between renal oncocytoma and eosinophilic variants of chromophobe renal cell carcinoma on renal mass biopsy. More work needs to be done to validate their findings. In comparison with the first poster of this session, where renal tumour biopsy is used routinely, we now move to a study where renal tumour biopsy is used rarely in the management of small renal masses. This study presents a single surgeon experience over 4.5 years of 210 robot-assisted partial nephrectomies. Only 4% had renal tumour biopsy before surgery. It is not clear how many patients who had renal tumour biopsy did not subsequently undergo surgery on the basis of the biopsy results, however. They report a positive surgical margin rate of 8% and report low complication rates. For tumours less than 2 centimetres in size, 25% were benign. For tumours 2 to 4 centimetres in size, 24% were benign. And for tumours more than 4 centimetres in size, only 9% were benign. And they conclude that there was a low rate of benign histology that was perhaps due to selection bias with patients initially managed with active surveillance. I would suggest that the rate of benign histology is not particularly low at 25%, and perhaps what would be expected for T1A renal tumours. However, if robot-assisted partial nephrectomy can be offered with very low rates of complication, those patients with benign histology on surgical specimen can be safely discharged from follow-up with certainty of diagnosis, whereas those undergoing biopsy and surveillance will have more scans, biopsy, perhaps surgery later, and live with uncertainty. So here is an argument against routine small renal mass biopsy. Now we come to 3 studies that report on ablation as a treatment for small renal masses. The first is a study from the Royal Devon and Exeter hospitals that looks at microwave ablation, and they treated 113 patients with this modality with small renal masses over 3 years. These patients were fit, with a median Charlson score of 0 and a median age of 68. All tumours were small, all less than 5 centimetres, and 90% were smaller than 4 centimetres. Complications were not insignificant, with 1 patient having a Clavien 3B complication and 1 patient a Clavien 4 complication. The median length of stay was 1 day, and the renal function change was minimal at -4%. 1 patient had local recurrence and required repeat ablation, and 2 patients developed metastatic progression. 6 patients had indeterminate findings on follow-up, which was relatively short at only 12 months. So these outcomes appear to be acceptable with this ablative technique, but it is not clear how these results compare directly to a surgical cohort or indeed other ablative technologies. We do not know how many patients in this centre had surgery in the same study period, and whether or not there was any difference in tumour or patient characteristics between these groups. The next is a study of percutaneous cryoablation for small renal cell carcinomas from the Royal Free and UCLH Hospital, and they report up to 5-year outcomes. 185 lesions were treated in 180 patients, and these patients had biopsy-proven renal cell carcinoma. Most, more than 90%, were T1A, and less than 10% were T1B tumours. The mean age was 68.4 years, which is very similar to the previous study, and the high-grade Clavien complications were similar at about 2%. Renal function was well preserved. No patient developed metastatic disease. 3 patients, 1.6%, had residual unablated tumours on the first follow-up scan. They had good follow-up to 5 years, but it is not clear how many patients had 5-year follow-up. The 95% progression-free survival, there was a 95% progression-free survival at 5 years. So a little comment here. There are many different ablative technologies, and we've just heard about cryotherapy and microwave ablation. Of course, RFA is commonly used in some centres, and there are newer techniques such as irreversible electroporation, which is a non-thermal ablative technique that uses short but strong electrical fields to create permanent and lethal nanopores in cell membranes. SABRE is not an ablative technology, but it uses focused radiation treatments that gives an intense dose of radiation focused on the tumour and has been used in the management of small renal masses, with more than 95% local control rates and low levels of high-grade toxicity. I wanted to draw your attention to a couple of studies that are investigating treatment options for patients with small renal masses. The first is a randomized controlled trial led by Maxine Tran at the Royal Free Hospital, comparing robot-assisted partial nephrectomy with cryoablation. They have completed a pilot study and will be looking to involve other centres shortly. The next study is EASE. This study is looking at the role of active surveillance in biopsy-proven renal cell carcinoma. The primary objective of this study is to look at the overall survival of patients managed conservatively with active surveillance, but they are also looking at outcomes such as growth rates. Evidence is currently lacking, and the outcome of this study will be important when counselling and treating our patients. So poster 6 is a comparison of EAU guidelines and the Eureka cryoablation registry. Do the guidelines reflect contemporary practice? So current EAU guidance recommends thermoablation of small renal masses less than 3 centimetres, only for cases with comorbidity or advanced age, making surgical resection undesirable based on a weak evidence base. And they've looked at their Eureka database. This is the European Registry for Renal Cryoablation, 11 participating centres from the UK, Netherlands, France, Denmark and Italy. In a 5-year period, more than 1,000 patients underwent cryoablation. The mean age was 69 years. Approximately 60% were ASA 1 or 2, and renal function was good with an eGFR of 80. Interestingly, 4% had metastatic disease at diagnosis. 40% of patients had tumours more than 3 centimetres, and tumours up to 8 centimetres were treated. Tumours were often of intermediate complexity. So they conclude that the results do differ from EAU guidance, which doesn't reflect current practice. They've been treating fitter patients with larger and more complex tumours. However, some patients had metastases at the time of treatment, so presumably these patients were being palliated rather than being treated with curative intent. This study doesn't report treatment outcomes, particularly oncological outcomes, so it is not clear whether the EAU guidance needs updating or whether it is indeed valid and there should be greater adherence to it. So outcome data from this registry would certainly be of interest. The third poster of this session from the group at the Royal Free and UCLH looks at the cost effectiveness of routine small renal mass biopsy. They describe their pathway 1, for patients with small renal masses who are offered biopsy. 677 patients were offered biopsy. 57 patients, 8.4%, needed a repeat biopsy. On the basis of these biopsies, 39% went on to have surgery and 23% went on to have ablation. This meant that 36% had no intervention, although interestingly only 3% were discharged and 33% then went on to surveillance. They compared this to an imputed pathway 2, where 91% had intervention and only 9% had surveillance, and it is unclear how these figures were determined. They calculated a cost saving of £1,380 per patient. This is an interesting study, reporting an economic argument for small renal mass biopsy, but perhaps overestimating the cost saving. There will be more patients on surveillance who over the years will need repeat imaging and consultation, may require repeat biopsy, and some of whom might come to later intervention, whereas those having surgery for benign lesions may be discharged immediately. There are, of course, advantages of biopsy, permitting a fully informed decision when making treatment decisions, and potentially avoiding unnecessary intervention and its associated morbidity for small benign lesions. So to summarise, small renal mass management remains controversial, but is perhaps now more important than ever, with an increasing diagnosis of small renal masses and the impact of COVID-19. The role of renal tumour biopsy is still being defined. There is a need for more research to determine the safety and effectiveness of treatment options for small renal masses, which all have valid roles. So the posters in this session should be commended for moving these debates forwards. I'd now like to hand you over to David Thomas, who will chair the remainder of this session. Thank you.
Well, thanks, Jim, for chairing the first part of the session. My name's David Thomas. I'm a urologist in Newcastle upon Tyne, working at Freeman Hospital, and I'm going to be chairing abstracts 8 to 15. So, starting with abstract 8, this is an assessment of lower ureteric excision technique associated oncology outcomes in upper tract TC, and that's presented by Mr. Blackmuir for the Scottish Renal Cancer Network. This abstract's been updated, so Tayside data has now been included, so it is slightly different from the published abstract you may have read. So 313 cases reviewed between 2012 and 2019 from 6 centres, with a median follow-up of 27 months. And they've looked at the outcomes in patients undergoing nephroureterectomy with different surgical techniques, either transurethral resection with pluck, laparoscopic excision, or open excision of the bottom end using either an extravesical or an intravesical technique. And if we look at the recurrence risks which are reported, there are some significant findings in terms of an increased risk of recurrence either within the bladder or the pelvis with high-grade ureteric tumours located in the lower ureter, or patients that had undergone previous diagnostic ureteroscopy. Of interest, with the new data from Tayside, a significant difference did emerge in terms of risk of recurrence for patients who had undergone transurethral resection with pluck. Also of interest was patients, there was no difference whether you'd had intravesical mitomycin or not, which slightly conflicts with the ODMIT study. So my take home was the role of biopsy and ureteroscopy. I think if you've got an obvious ureteric tumor, a solid enhancing mass, whether you need to do a biopsy, there may be a downside with increased risk of seeding. So that's something to take on board. And the increased risk with transurethral resection of pluck. And now that we've got robotic techniques with more accurate visualization of lower end and suturing, perhaps it's the beginning of the end of the pluck, and a strong argument for pushing forward with the robotic technique. Okay, so we move to the next abstract then, please. That could be abstract number 9. Just waiting for that to come up. There we are. So this is an abstract from the Royal Marsden Group, David Nicholas, lead author. The robotic RPLND with single agent carboplatin in low volume stage 2 seminoma patients. And we've seen some pilot data from the Marsden in this group, in, I think last year, and we now move on to 3-year outcome. So 40 patients underwent robotic RPLND. This is, just to remind you, is patients that have had pure seminoma on their orchidectomy specimen and on staging PT2A, in other words, nodes less than 2 centimeters and normal markers. Historically, these patients would have probably received dogleg radiotherapy or possibly chemotherapy, and there are survivorship issues with the long-term effects of those treatments. The histology from the RPLND showed that 3 patients had no tumor and in fact was benign, so they didn't need any treatment, so they were spared additional treatment. 2 patients had embryonal carcinoma, went on to get BEP chemotherapy, and 1 patient relapsed at 18 months. 37 patients went on to successfully receive adjuvant chemotherapy and are doing well on follow-up disease-free. So key points, this is a safe technique at 3 years. It gives you more accurate information as what's going on. Some patients didn't need treatment. 2 patients were changed to BEP for their embryonal carcinoma. And I think it's time for a national trial to look at this in more detail. I'd be keen to see this rolled out. We could also offer open RPLND for this group of patients in centres with smaller numbers. I think the benefit, even if not conducted in a minimally invasive fashion, of avoiding chemo dogleg radiotherapy may be a strong argument. So I think a really good abstract, exciting, and perhaps we can now encourage a national study to follow on. Moving on, next abstract, please, is number 10. And this is non-germ cell testis tumors, 22 years experience from a tertiary centre. And Dr. Kate Quirk presents for the QE Birmingham group. And they've gone through their database over a 22-year period and found 23 patients with sex cord stromal tumours, so benign tumours. Of these tumours, 76% were Leydig, 19% Sertoli, and 5% unclassified. And of that group of patients, 57% underwent partial orchidectomy, so sparing testis tissue, and they report successful outcome with no recurrence and no mortalities. 1 patient had high-risk features on the initial partial orchidectomy and moved on to a total orchidectomy. So this does seem to be a good and a safe option for these benign sex cord stromal tumours. I think the difficulty is how you diagnose them in the first place. So selection is absolutely key, and you need to have a strong lead from your radiologist, whether it's on ultrasound, whether it's on MR, so that you can pick the patients that would be suitable for this, because of course you haven't got the histology before you do the orchidectomy. There may be some features, I don't know whether some of these patients had elevated testosterone or there was a clue that it was likely to be a Leydig. So I think a little bit more information on how we select these patients, but nice to know that it is a safe option when you get the diagnosis right. And just a reminder for germ cell tumours, a different kettle of fish, and in those patients there's a very high incidence of intratubular germ cell neoplasia. So partial orchidectomy, very different in the germ cell tumour setting. Okay, so moving on to abstract 11. This is presented by Mr. Lucock from Dundee, and this is a comparison of CT and MR findings for patients with complex renal cysts using a Bosniak score, patients undergoing surveillance. So they have trawled their database and found 452 patients with complex renal cysts between 2009 and 2019. And in that group, there were 32 patients who'd had both CT and MR. And they compared the outcome in that group to see whether there was a close correlation. The numbers are relatively small at 32, but what they report is no significant differences whether the patients were having CT or MR, so good correlation, and there was no stage migration requiring surgical intervention, so no patients as a result of a change in modality missed the boat in terms of operative intervention. Looking at the more complex cysts, the 3s and the 4s, I think there were 12 Bosniak 3 cysts and 1 Bosniak 4, and there was good correlations between CT and MR, so further reassurance in the group of patients that perhaps would have had surgery. MR, clearly less radiation, so benefits over CT with associated radiation risks, and it is presenting more data to encourage MR for surveillance of these complex cysts. As a side issue, I was looking to see any data on how long to follow our Bosniak 2Fs for, particularly in younger patients. It's not easy. And I wondered what the histology had been from patients that had had surgery in the 3 and 4 classification group. But nice reassuring data, so that if we do switch from CT to MR, we can be reassured that there is close correlation. Thank you. So next abstract is number 12. Thank you. So this is looking at nephrometry scores, a validation of 3 systems to predict perioperative outcomes in retroperitoneal robotic partial nephrectomy, and that's Mr. Crockett on behalf of the Frimley group. There are a number of scoring systems out there, and this is particularly looked at a scoring system named SPARE, which is a modification of the Padua scoring system with which you may be more familiar. It has 4 variables rather than 6. And what the authors have done is compared 3 different scoring systems, the renal score, the Padua score, and the SPARE score, to see if they can all predict the trifecta being aiming for good outcomes with positive margins, with preservation of renal function and low complications. 32 scans were looked at by 3 separate observers, with the main focus being on operating time, blood loss, and warm ischemia. In this small group, the Padua and SPARE scores predicted the trifecta. Trifecta was met in 59% of cases, and it was a warm ischemia time of 23 minutes. So the SPARE scoring system is attractive because it is relatively easy. It's simpler than the Padua score. It's reproducible. It does the job. And in the data, there was also no difference between anterior and posterior located tumors. So SPARE score came out well in the study and would seem a reasonable scoring system to use, a bit simpler than the Padua. So abstract 13, it's nice to see the Baus nephrectomy audit data used, and Miss Whiting on behalf of the Baus nephrectomy audit group has looked at complications after radical nephrectomy for renal cell carcinoma according to age. So having trawled the data set, she found 18,438 patients, and they were allocated to different age groups, less than 60, 60 to 79, and greater than 80. So not surprisingly, the vast majority of patients underwent laparoscopic nephrectomies, and there were some significant differences between the age groups, probably that you would expect, but reassuring to see the differences. The T stage was higher significantly in those greater than 80. There were more node positive cases in patients less than 60, and there were more cytoreductive cases in patients less than 60. So that was probably what you would expect to see in terms of clinical practice. Very few partial nephrectomies in the elderly patients and very few cytoreductive nephrectomies in the elderly patients. That all fits. They looked specifically at complications, and there was a link with age. So particularly in terms of bleeding and transfusion rates. The transfusion rates were probably a little bit higher than I would have thought. So in the less than 60 group, 7.6%, 60 to 79, 8.6, and the greater than 80 group, 9.1% of patients had transfusions. There was also a high instance of chest infections in elderly patients. But significantly, age seemed to be an independent risk factor. So it wasn't just the performance status in those patients. Independent of performance status, age was a significant factor. And so perhaps we should take this into account when we're thinking about consent and we're counseling patients. So age is not just a number, it is also a predictor in this series of patients. Next abstract, please. Abstract number 14, the ACE in the hole, managing intractable chylous ascites following laparoscopic nephrectomy. And this is Mr. Panwar on behalf of the Super Specialty Hospital in Delhi and University Hospital North Midlands in Stoke. Chylous ascites, chylous leak, can be a significant clinical problem, rare but difficult to manage. And they've looked at 2,378 cases of lap nephrectomy. And as a consequence of surgery in these patients, they discovered 118 patients who had suffered from a chyle leak. These surgeries they'd had were predominantly either laparoscopic live donor nephrectomy or laparoscopic radical nephrectomy. And again, the vast majority left-sided, as you would expect. Cisterna chyli, most likely the cause of the leak. So of these 118 chyle leaks, after 2 weeks, the vast majority had settled, and they were left with 6 patients that hadn't settled on conservative management. 2 then went on to low-fat diets and settled, and 4 had intractable chyle leaks, which were treated with TPN and octreotide. In 2 cases, this was successful, and in 2 cases, surgery was undertaken laparoscopically. It was difficult to say exactly what timing that was, but I think it was around about 12 weeks from looking at the poster. And at surgery, using either a clip or a suture to oversew a chylous leak, the chyle leak was controlled. So I think the abstract is a timely reminder of chyle leak. Remember to consent patients as this is as a risk. A reminder that vast majority will settle with conservative management, and a reminder that there is a surgical option. There isn't very much in the poster to say exactly how they found the chyle leak, and I can imagine 12 weeks after lap nephrectomy with the bowel stuck down, it might be quite difficult to dig out the source of the chyle leak. But anyway, technically possible and an option at 12 weeks. If you'd waited another month, I wonder whether those 2 might have settled, but we'll never know that. But a very timely reminder on the management of a chyle leak. And the final abstract is number 15. Thank you. So abstract 15 is a validation of the grant score for the US population to predict survival in surgically treated renal cell carcinoma, and that's presented by Mr. El Hadi from the Faculty of Medicine in Tripoli in Libya. Now the grant score, I think, was drawn up by an Italian group, Marco Bandini, and now has been looked at and validated in this very, very large group of American patients. So the authors have gone to the SEER database and identified 84,245 cases. So it's a very large cohort, and applied the grant score, which is a very simple scoring system, which is the beauty of it. And you get a point for grade greater than Fuhrman 2, a point for age greater than 60, a point for nodes greater than 1 pathological node, and for stage T3B or greater. It differs from the UCLA UISS score and the Leibovitz score in so much as you don't need the complex pathology input, and there can be variation in pathologies, particularly when applying, say, tumor necrosis and it makes it a much easier to use scoring system. And it's validated in this sample, showing clear prognostic benefit, distinguishing the groups. It is extremely simple, but the power of this study is that the fact that in 84,000 patients, so a huge sample, it's proved very effective. And I think it is something which you can use relatively easily in the clinic, because the information should all be to hand to apply the scoring system. So it's certainly something I'll have a look at for my practice. That brings me to the end of my part of the abstract session. I'd like to thank all the contributors for their submissions. I hope you all enjoy your virtual BAUS, and I'm very much looking forward to seeing you in Liverpool next year. Stay safe.